If you are in a rural location, your accessibility options to quality rehabilitation drastically lowered than your metropolitan counterparts.
You can't rest pain better, you need to train it better.
I'm Mariam Tadros, and joining me today is Aaron Bowes. Aaron is the National Manager of Pain and Recovery Services at IPAR Rehabilitation, where he leads the design, delivery and national implementation of innovative evidence-based models for clients experiencing persistent pain. Aaron is a qualified exercise physiologist with a strong background in occupational rehabilitation and has spent over a decade supporting injured workers to recover and return to meaningful work and life roles. Now, IPAR's Rethinking Recovery program has evolved into a scalable telehealth service that blends contemporary pain neuroscience education, one-on-one coaching, and immersive virtual reality. Aaron, welcome.
Thank
I'm
you very
so
much.
keen to talk to you about this. In terms of supporting people that are in rural locations, we talked a little before the session started about the postcode lottery and the sense that, regrettably, if you are in a rural location, your accessibility options to quality rehabilitation, medical care and continuity of care are drastically lowered than your metropolitan peers or
Absolutely.
counterparts. In your line of work, it sounds as though you've been trying really hard to think about some practical solutions to bridge that gap and help people in those areas. How does Rethinking Recovery address that pain care gap for rural and remote Australians?
Yeah, I think you've touched on the key barriers that we saw that were or that we see that are the catalyst for us developing the telehealth model of the service. But, if I could go back to probably 4 years ago, we kind of had a bit of a lofty goal. Firstly, how do we improve pain care within compensable schemes? And rather than being a reactive model of care where we follow stepped care and we only give pain notice or attention when all else has failed, we know that if we can change someone's understanding about pain earlier, then perhaps we could fast track their recovery. And so our goal was, how do we develop a service that can support people across Australia, regardless of their location, to improve their recovery and return to work. And so even to bridge that regional and rural care gap, we tried to achieve that with our face-to-face version. And so we've currently got 85 pain coaches across Australia. And one of the strategies at the start was recognizing that regional and remote clients have poorer outcomes. We need to have a regional availability of our pain coaches. And so we've got, Goulburn, Albury, Tamworth, Darwin, Bunbury. But even having that spread, there was still the real regional and remote clients that we couldn't access with our face-to-face service. And so we spent the best part of 2 years trying to figure out how do we actually achieve that. We know that there are those barriers associated with being in a rural area. But we also know that there's some key pieces of work that have come out to say that we need to prioritize digital solutions for regional clients. How do we look at telehealth as an acceptable model of care for clients? And there's been some great research that's come out, a lot of it probably this year. And there was a study in the journal of the JAMA journal that looked at the acceptability of a telehealth model of pain care. And essentially, it outperformed usual care in terms of pain outcome measures, or was seen to be superior to a certain extent, and the outcomes were sustained. So it kind of led us to believe, okay, if telehealth could be part of the solution. And so we were trying to figure out how do we deliver our current model in a telehealth model, understanding that there are barriers that we foresaw, which was health literacy, cultural diversity, technology challenges, internet access. But our goal was first to look at, okay, what's the opportunity? And that is, how do we deliver something that can reach anyone regardless of location, that doesn't require wait lists, travel time, that delivers an evidence-based care model, and then we'd figure out all the other strategies. And so the biggest challenge initially was probably work health and safety implications. If we're sending out a virtual reality headset, like, how do we deliver that model safely when our pain coaches aren't there? And so what we've done to address that, we work really closely with our broader business med health group to go, how do we do a large risk assessment and come up with triage processes and a risk assessment tool to make sure that people are safe to engage in this service. And so we've extrapolated the service a lot to make sure that there is some triage before we even start, before we even send out a headset to the client as well. And then there's a familiarization session, a lot of other supportive resources to make sure that people are actually suitable for us to send out the headset in the first place. And then we're doing a bunch of work with University of South Australia at the moment, looking at the barriers and enablers to telehealth care, telehealth pain care through our model. So doing some work in WA at the moment on engaging with pain coaches, but also clients that have gone through it to analyse more of a thematic analysis on what are the barriers to care and how do we improve it.
Now, tell me, what do you think? I mean, we've talked a lot about the barriers there and what you're doing to tangibly get a handle on them. But how do you think the virtual reality experience compares to the traditional approach? You did mention earlier that in some cases it was better outcomes.
Yeah.
Tell me a bit about that difference.
Yeah. So look, where virtual reality was a key part of our service and something we're very passionate about is, I refer back to the conversation 4 years ago with arguably the world's leading expert, Professor Mosley. It was how do we make pain education better? How do we make it scalable? And how do we get people to buy into it? And the research is quite clear that clients impacted by pain don't buy into the traditional didactic kind of learning using apps and face to face and someone telling you what to do. So the immersive nature of it was really exciting, that rather than telling people analogies that we know are important to get across, they can experience it. So they can experience it, they can immerse themselves in it. It also gives them an opportunity to take control over their kind of pain education. And so it's less about us telling them what to do and they're doing it, engaging in it. And then after they've finished in the headset, if they're only in for 10 to 12 minutes, it's more around how do we contextualize what they've learned to their pain experience. Because often, in some instances, when we do like the group-based pain programs, we sometimes lose that individualization, or how do we make it relevant to your pain experience where you might have these influencing factors or cultural beliefs, past experiences or behaviors. And so it allows for an individual approach and also a component of a standardized approach as well, because, there's some great research showing that healthcare practitioners find pain education quite difficult to deliver. We also know that people impacted by pain don't buy into it, but then people that have recovered from persistent pain say that was the most important part of their care. So there's this kind of continuum that we need to break, and we think that VR is an evolution of that. There's some really, really great research that essentially shows as a tool, it can enhance learning by 30 to 50%.
Amazing.
And that's outside even the pain space. That's not standalone to the pain space, but consistent systematic reviews that have looked at that as well.
And that really talks to the nature of learning. So learning is, if we say it as a 70-20-10 model, 10 is your traditional classroom-based, or I'm doing a learning module online or whatever it is. 20 is exposure opportunities where you might shadow someone doing that thing. 70% of your opportunity to learn comes from experience itself. You're doing it. So if you're learning something on the job and you're performing in the role that you're supposed to be doing, that experience in practicing the on-the-job application of the task is what is the biggest contributor of you getting it, whatever it is that you need to get it. So if you're in a completely immersed experience where your senses are enveloped in this, then your speed to competency is accelerated, I would imagine.
Absolutely.
Yeah.
Absolutely. And it kind of, the experiences and the learning is one of the core objectives, because pain education is not the goal. It's learning about pain that's the goal and being able to apply it. So how do we get people to experience it but then apply it? So the classroom components, we have a few worksheets that we do, but that's just to cement kind of the learnings that we've gone through and the reflections. But for us, the VR is just such a unique way of changing learning about pain. And there's this concept that Pain Revolution and Professor Mosley is around, is how do we make pain education better? And I'm very confident that VR is part of that journey.
Yes.
How do we make it more palatable, more consistent? We also know what are the key messages that we need to get across when we talk about pain education. So some great work from Dr. Hayley Leake, looking at what are patients impacted by pain value learning about pain. And so they interviewed 350 people they asked them what were the key themes or the messages that were the catalyst for you improving. And then that was did an analysis sent around to world-leading experts, and they came up with what we call the 4 essential pain facts. And so these are the 4 key pillars that we know that people that have recovered say that are the most important part. So VR is a tool that can make learning about the key things that we know that are really important to understand easier to understand.
And I imagine if you're in pain and may have poor mobility as a result of the pain that you're in, being able to be in a fixed location and still have a very immersive experience without having to stress the injury is highly advantageous. Now, if I'm imagining myself as a rural resident and I've regrettably hurt myself and I'm interested in having VR support me in my pain recovery journey, talk me through what's the process of me being able to access one of these units, and perhaps we can even do a bit of a demonstration of, well, this is what I'd receive in the post.
Absolutely. So it really depends what scheme we're in. You know, the way that it's delivered is completely different. But if I was to kind of wrap it up, we receive referrals nationally from GPs, allied health, from insurers, and from rehab providers as well. So our kind of core criteria is pain greater than 12 weeks, primary physical injury, and its impact on their recovery and their return to work. So what we have done is equipped all those key stakeholders with all our resource about what the service is so that they can share that with clients that may be impacted in pain. So if you're visiting your GP in Tamworth, and the GP might be aware of the service, if they understand that you've got a compensable injury, you may not be improving with your traditional treatment or your return to work, then this could be offered as a complementary service to treatment. You know, this is an education-only intervention, and we're certainly not saying that education as a standalone intervention is effective. It needs to be done with good, high-value care and treatment. And so we partner with a lot of allied health clinicians to do it. And I think that's the important part to get across to clients is this is a supportive service to complement what you're doing. And so essentially, let's say, you've gone to your GP, they introduce a service to you via a video or a flyer that we've got, and it's something you want to participate in. You know, referrals can come direct from GPs or insurer direct. Our team would receive it. We would allocate to one of our pain coaches, where it's a face-to-face or a telehealth pain coach. We've also got a hybrid model that, depending on the client situation, we can do a few visits to their home. And then we do the rest via telehealth, or vice versa. They can come to us and then we do the rest of it telehealth. We can do it completely telehealth. And you touched on a good point, like travel burden and pain. That's a big thing. So if a client says, like, I just can't travel long distances, it flares up my pain, we wanted to have an opportunity that, how do we support you? And we've had some really great feedback from clients saying, I've been able to do this in the comfort of my own home without traveling. We've also concurrently run this in physio clinics in regional areas where they might have gone to their physio. We're booked in with them. The physio sets them up in a separate room afterwards. We're telehealth just with the client. The physio is treating another client. And so it's continuity of care that straight after their physio, they've got our service as well. And so then we would give you a call as a client, introduce the service and how it's designed to support you. We'd run through some triage questions about like safety, how would you safety space that you may have in your home, internet access, familiarization with technology or comfortability with technology, family support, people that may be able to help if you don't have the confidence. And if we think that it will be a great service for you, we'd send out a package that looks exactly like this. It's got a VR headset, 2 controllers, and a charger.
Okay, let's have a little look at that. We might just open it this way so that we can see. So you've got this that comes through. You have the...
It's stuck in there nice and tight, please do.
Yes.
Yeah, it's nice and tight so we don't get any broken ones.
You get this, that obviously gets popped on.
Yep.
It's completely immersive.
Absolutely.
And comfortable.
Yep.
From what
and
I can
even before they turn that on, we've introduced a familiarization session we do before we even start the VR, and that's we give them access to a unique client portal which is completely online. It's got how to set up your VR headset, how to connect to it, but then every session it's not self-directed, so you don't just jump in the VR and you don't have the support there. So our pain coaches are always on a telehealth model with you. So Teams, Zoom, or on the phone.
Yes.
And so we support them through every step of the way. So, even we do a familiarization session just to confirm your comfortability being in VR and to talk through looking at your hands, how to access the buttons.
Yes.
There's a toggle at the back. So depending on your functional tolerances, you can do it seated or standing. And we can adjust that as well. So we've had people do it completely seated. And then the first session and most sessions, they're only in there for 10 to 15 minutes. And the most important part is to take them out and go, okay, let's discuss it. And how does it apply to your pain situation?
And in using this, which is it's such a unique opportunity, it's I suppose we're on the frontier of these things now, and perhaps in a little while, in a short while, this won't be innovative any longer. It'll be business as usual, and it's just another tool in the box to support.
Absolutely.
Telehealth, sort of perhaps pre-COVID, wasn't as popular, but post-COVID, people are almost preferring to just have a telehealth consult rather than having to go in. This is a completely better evolution of that process.
Absolutely.
What outcomes or results have you seen from patients that have used this product that perhaps traditionally might not have been a patient that would have immediately or innately drawn themselves to using technology as a learning tool?
Yeah, so we've done over the 4-year journey, we've done a range of different analysis of outcomes, and that started for us with probably our first analysis where we looked purely at pain-related outcome measures, and we compared ourselves against some of the standardized data set from the Electronic Persistent Pain Outcome Collaboration, and we were you can't compare apples and apples, but quite strong results in terms of pain self-efficacy and fear avoidance and clinical significant improvement in those measures. But for us, we really wanted to be incredibly cost-effective and not have a wait list, and we know that's one of the challenges with some of the pain services across Australia. So to see those outcomes come out quite comparable to those programs, but a significant cost saving and no wait list and scalability allowed us to really demonstrate to insurers and regulators that this is a viable option that aligns with our objective, which is to be cost effective and effective at improving pain-related outcome measures. But then we wanted to look at, okay, what are those measures that seem to improve the most? And so our next analysis essentially looked at the key outcome measures that we look at. And there's a range of ones we look at, but for example, we wanted to see pain self-efficacy as number one. We know that if we can improve someone's pain self-efficacy, there is an association between reduction in pain and improvement in function, and we hypothesize that may translate into people having increased capacity to progress with return to work or have a greater function. And so in an analysis of 220 clients, what we showed across most clients is we were seeing probably about a 30% improvement in pain self-efficacy, which was quite significant.
Amazing.
And that was only to be beaten by a significant improvement in pain functional interference, which is a byproduct of the brief pain inventory question.
Yes.
Which is about 33%. We were really confident with that because it means that people are increasing their understanding about pain and their confidence, but it's also interfering less in their function.
Yes.
And then we've been able to take it away from the pain-related outcome measures to go, well, how do we actually enhance return to work outcomes? And so in a state-based pilot, we demonstrated that of the clients that had no capacity for work that did the service, upon completion, within 3 months of completion, 68% had a capacity upgrade versus the scheme of 23.5%, and 33% achieved a return to work versus 16.5%.
Yeah, there's a really impressive data-driven insights there that talk to that.
And I have to be clear though, that was predominantly looking at our face-to-face model. So we're in the process of doing that study with University of SA on the barriers and enablers to care, but we do need to do, and we are doing through our med health research team, an analysis of the telehealth model and the effectiveness as well. So we hypothesize that it may bridge the gap, but we've had 90 clients go through it. We just need to start analysing that data as well.
Well, they're very strong lead indicators in any case. We know that our rural communities are in need of some solutions that can support them in the disadvantage, really, of being not able to access healthcare when you need it most, and having those exacerbated wait times, and then not having a continuity of care because of the sort of roulette of GPs and specialists that are available to you. So something like this certainly sounds like it's going to afford them a way to work around those challenges in a way that's meaningful and impactful for them. And I imagine also that it would support them in their psychosocial lead indicators too, because they're empowered to do something for themselves while they're in that waiting period, which is fantastic. So it's cutting down a lot of those risk factors. It's an active mitigant in a number of areas that all of those things cumulatively will cut down your recovery time and will cut down your anxiety around your injury and give you confidence that maybe you can do more than what you thought or assumed that you could do.
And I think that's such a great point you make. It's giving them confidence. When we talk about pain and compensable or a workplace or a motor vehicle accident, and pain persists, clients kind of lose their internal locus of control. They're told what appointments they have to do. They get told they can't bend, they can't twist. You've got to do this, you've got to do that. And so what we're trying to do is firstly educate them about pain, and that you can't rest pain better. You need to train it better. But then once we can get them to understand that, they know that they can take a more active approach in terms of their pain and recovery as well. And for me, if you look at the different challenges we see with the original clients are obviously increased use of opioids, high interventions, high accesses to low value care. We look at what are the risks associated with VR. There's not a lot. Using VR, there's not a lot of risks, whereas we look at risks of opioid use, high-risk medication, some surgical interventions that come with risks.
Yes.
The only risk is, we might scare a client because rather than talking about a key analogy of the Twin Peaks analogy or a cliff, we put people on a cliff. And so there's no risks of using it. And so we just think we think it is the future of kind of rehab for pain. And what we're certainly not saying is this is not the solution for everyone. We can't say that an education intervention alone alongside a treatment is the silver bullet, because we know multidisciplinary care is
Yes,
is
but
gold
but
standard.
it's part of the disciplinary care that's now available, and it's a high advantage because there is a sizable gap in what's available for rural clients. So for their opportunity to get a high duty of care service that's there for them and can reframe us. A lot of it is around our psychological framing of the injury. This is a wonderful thing that you're doing. Aaron, thank you so much. And thank you
Thank you very
to
much.
Rethinking Recovery for their innovative way and their approach and their diligence to support our rural clients that are, in need of this support and this care. It's a wonderful thing that you're doing. Thank you so much for your time.
Thank you so much for having me on. Always a pleasure.